So, hello and welcome everyone. Is it not working? Oh. Maybe I need to put this a little bit closer. Down. Okay. Sorting out the microphone. So, hello and welcome everyone to our symposium on Voices that Drive Change, Navigating the Future of Pulmonary Fibrosis Together. I'm Friederike Medicke and I work on the Global Patient Engagement team at Boehringer Ingelheim. It's a great privilege for me to share this symposium today, where hopefully we're going to have many new insights. I know some fantastic initiatives we're going to hear about, and a great exchange both in the room as well as online. Now, for those of you online, you may have seen the slide already a little bit, but also in the room, you've heard in the introduction from Alba about the Swap Card app, and we want to have a conversation and interactions with all of you. So, Swap Card can be used in two ways. You can either ask your question for our discussion later, but we're also going to ask you some questions, as you can see here. So if you scan that QR code, this is going to take you to our session. Then you have to click on live interaction, and then you have to click on poll. And then we have a first question to you on if you feel that over the past decade, awareness of pulmonary fibrosis has improved in primary care. We're going to take a look at what you think about that later on. But let me tell you a little bit about what we're going to talk about in this session. So I'm going to have a short introduction, and then we're going to really want to draw on the expertise and experience that is gathered here at the summit. We really know that shaping meaningful change takes a community, just as it takes a village to raise a child. And what is really important for us that together we can move from insight to action. I really liked the image that John had up this morning about bursting some bubbles together. So I hope that actually this is something that we will be able to do today. After a quick intro from me, we will have three very inspiring perspectives on care gaps and what can be done about them. And for that, I'm joined by three fabulous panelists who are actually representing the different perspectives that we have in the community, from living with pulmonary fibrosis, caring for someone living with pulmonary fibrosis, and treating people living with pulmonary fibrosis. So it is my great pleasure that we have with us Eleni Stamouli from Greece, who is a volunteer for the Greek pulmonary disease organization Breath Association, a member of the ELF Pulmonary Fibrosis Patient Advisory Group, and was herself diagnosed with pulmonary fibrosis in 2019. She had exactly established her own business and successfully ran her company for many decades until she was diagnosed with pulmonary fibrosis. Eleni knows from her first-hand experiences what challenges there are to navigating a complex disease, starting with diagnosis and treatment to the emotional impact it has on everyday life. And she is using her voice to help others going through similar journeys, making sure that patients are heard and involved in shaping the future of respiratory care. Then we also have Tom McMillan with us from Northern Ireland, who has dedicated to supporting pulmonary fibrosis patients and families in Northern Ireland since his wife Una was diagnosed with pulmonary fibrosis in 2016. And I'm very glad that Una actually is also with us here. As a chair of the Pulmonary Fibrosis Northern Ireland Support Group, Tom runs a support network for patients, families, and carers, and organizes weekly meetings that allow people to share information, advice, and their personal experiences. And offering this support to patients across Northern Ireland, his efforts have enabled him to create a community of people who all face similar challenge and support each other through their journeys. And then we also have with us Professor Anne-Marie Russell from the UK, who holds the Jenny Jones Chair of Nursing Science at the University of Birmingham and is the School of Nursing and Midwifery Head of Research and Knowledge Transfer. She has research expertise in mixed methods and person-centered approaches in interstitial lung diseases, and maintains a portfolio of contemporary practice in research, research leadership, clinical practice, and education. Most importantly for herself, her research is patient-centered, working with patients as partners from conception to outputs. And she is also an active member of the European Respiratory Society, working on developing international clinical guidelines. And since the inception of the EU PFF, she has actually been on their scientific advisory boards for all of those past 10 years already. So I'm sure we are going to have a fabulous discussion with our three panelists and we'll be able to learn a lot from them. We will have time for a discussion with you at the end after we've had their presentations. But actually, as we have heard in the first session, and I should have shown that slide as I was introducing my panelists. My apologies for that. Two took up in my notes when it came to that. As we heard in the first session of today, actually a lot has happened in the PF space since the beginning of the 2000s, and probably even more since 2016 when the EU PFF was established 10 years ago now. So it's fair to say that there's growing recognition of pulmonary fibrosis and lung health overall as a public health challenge. This is also reflected in the World Health Organization's lung health resolution that was issued last year in May, which explicitly actually calls out pulmonary fibrosis as a priority. So this is an important sign that the lung health is finally higher on the global agenda. However, even as awareness and recognition are increasing, the key questions that we have to continue to asking is, does that translate for people living with pulmonary fibrosis? Is there meaningful change in the lived experience? Or is it actually the case that there are still too many gaps and too many disconnections that we need to address? And I think it's fair to say that if we look at the program of the summit, there are still many things that we need to continue to work on together. And the important thing, I believe, is together, getting out of our individual bubbles to really understand the gaps and take action to address them together. One example that we have been involved that I would like to share, if the slide moves to the next. I should probably click on the right button. Yes, there you go. One example of co-creation that I would like to share has been the Bridging Care Gaps report, which we have been working on together with patient advocates, healthcare professionals, as well as industry together. And here we work to identify important care gaps that continue to persist along the PF care pathway from diagnosis on to ongoing management. And if you look at these, and on some of these, our speakers are actually going to touch on in their inspirational talks that they'll share with you. This really does reinforce a critical point. Progress is most meaningful when it is shaped by the priorities of those living with the disease and if they are addressed through collaboration, which is why we are here today at this summit. So I'm happy to say with our panel, we will be working on that. We will be working on bursting the bubble and bringing together lived experience from the person living with the disease, the carer, and the healthcare professional perspective. And this also, the community does include you as well, our audience. So if we could please take a look at the results of the first poll that we had issued at the beginning of the session and see what your perspectives are about the awareness. So I think that actually does talk to the fact that there's still so much more to be done, does it? Half of you have said there is an improvement. A third says, actually, no, when we're thinking of primary care, so the general practitioners or the family physicians, it has not improved. And 20% say, well, I don't really know. That's definitely interesting to know. And maybe we can contribute to that a little bit with our thinking and our talks today. Now with that, I would like to invite our first speaker to come to the stage here. So Eleni, if you would please come to the lectern and share with us your experiences. Push on that mic. Push on that one.
Yes, yes. Good evening, and from me, I'm very glad to be with all of you, and I thank AUPFF and Boehringer Ingelheim for the invitation. I have to say some things from my experience and from the experience of my co-patients. When someone is diagnosed with pulmonary fibrosis, the first focus is in treatment. But pulmonary fibrosis is very complicated disease, and medicines are not enough for this. This inspired me to talk about pulmonary fibrosis. Yes, pulmonary fibrosis, living versus treating. When someone is diagnosed, very quickly understand that he has to face a different reality. This reality has a lot of changes and a lot of losses. And the new reality includes breathlessness, fatigue, anxiety, and isolation. And of course, you have to stay in home and lose your independence. The main question is, how do I live with this disease? The diagnosis tells you what disease you have. Don't tell you what you will live with this disease. There is a fundamental gap. I go there. There is a fundamental gap between managing the disease and supporting the person living with the disease. The most important gap in pulmonary fibrosis is the lack of an holistic approach to this disease. And a very significant part of this holistic approach is pulmonary rehabilitation programs. Because all who live with this disease and our families, we understand that if you have pulmonary fibrosis, if you have to deal with such a very bad disease, you don't only lose your your lung function, you slowly lose part of your everyday life. In the rehabilitation programs, if a patient has the opportunity to be part in a rehabilitation program, this really can change your life. In my case, I was lucky enough, and from my diagnosis in 2019, I had a rehabilitation program in my clinic. It was working from 2017, and it was a collaboration between my clinic with Aristoteles University of Thessaloniki, and it was funding for Boehringer Ingelheim. This is what was the first step in order to take care for myself, to get out of my depression about what happened to me. And this program, which is continuously working in Thessaloniki, this is a very excellent example of a good practice and an effective cooperation between a pharmaceutical company, a healthcare professional, a scientific team, and patients. This program, which I showed it, I presented you in this slide, this program is divided in two parts: a short-term rehabilitation program for 4 months, a long-term rehabilitation program in which patients continuously participate for 5 to 8 years. I'm in this program from 2019. I'm already 7 years in these programs. And I have to stay in long-term rehabilitation because we usually talk about the need of rehabilitation. There is need of rehabilitation, but in our case, in the case of pulmonary fibrosis or other pulmonary disease, rehabilitation has not to stop because the disease will not be cured. It will continue. We have something that we have to continue and have it all the times. And the next step of this program is to go to the community, to pass in the municipalities in order to have the patients through their municipality to have rehabilitation programs and go and get off from the hospitals. During these rehabilitation programs, was constructed home-based exercises for participants with pulmonary fibrosis. This project was constructed by Hellenic Thoracic Society in collaboration with exercise physiologists from Aristoteles University of Thessaloniki. And this is available for all patients all over the world in two shapes, in the shape of a brochure or a video, and you can use it and have a home practice when you want and when someone needs to do it. And it's very important because we are not all living in the cities, in big cities. We have rural areas, we have islands, we have people that cannot have access to rehabilitation programs, and this is a solution. This is a solution, but all of this must be under the control and the monitor of our doctors. No one can do something if he don't speak or discuss it with his doctor. About λοιπόν, however, my experience is not the reality for most patients. Across the pulmonary community, many patients have no access to rehabilitation, many are not referred early, many must search for support on their own. However, pulmonary rehabilitation is very important for us, and it can give us part of our life back. And what is offering to us? Offering exercise and breathing techniques. Exercise is something that we need as patients because this will strengthen our body, and we need a strength body. Breathing techniques, no one in his life had to learn how to breathe, but we must learn how to breathe again. We must breathe, we must to extend our inhale and extend our exhale. No one do that, and this is the most difficult part of a pulmonary rehabilitation program. It offers education about our condition and and how we will manage our condition, how we must to understand our body. Our body gives us signs to do what we have to do, but we have to learn to hear our bodies, and they give us confidence and control. Control, I think this is a very significant word, because we have to do with a very uncontrollable disease. It's a disease in which in one day you are very good, in the other day you have such symptoms that you don't recognize yourself. And of course, in all this, we have to, what it gives us all this, we give us it gives us better symptom management, less, I can't see what I'm writing, less isolation, improved quality of life. All these are very important, and we can discuss about every topic for a lot of time. And rehabilitation, what we can expect, rehabilitation will not cure our disease, but rehabilitation will give us the chance to live better. And of course, finally, rehabilitation, if we truly listen to the community voice, the message is clear. Rehabilitation is not luxury, it's essential, not optional care. Access to support should not depend on how lucky or informed a patient is. And for all these reasons, we have to push to get more. You have to push to integrate pulmonary rehabilitation in the standard care of pulmonary rehabilitation. We can fight for all of this that we need as patients, and you have always to have in our mind that living longer has no value only if we can live better. This is that we want all, and I'd like very much in the end to have a discussion about all this and to hear from all of you your opinion and your experience about rehabilitation. Thank you very much.
Thank you very much, Eleni, for sharing this perspective with us. So next up, we have a little poll to the audience, and maybe we can see the next slide, to ask if what Eleni has shared about the pulmonary rehabilitation should also be a priority in your country. And as you're responding to this, I'm happy to introduce our next speaker, Tom McMillan from Pulmonary Fibrosis, Northern Ireland. So
Yeah, good
Tom,
afternoon,
the stage
everyone.
is yours.
Thanks very much, Eleni. I would have picked that subject myself as a care gap because it's certainly a care gap that exists throughout Europe. I'm sure many of you have experiences in inequality with rehabilitation, so thank you. There we go. So for me, there's so many care gaps for pulmonary fibrosis patients, and there's many that I could have picked. You know, it does impact everyone's life. There's many support needs and there's many unmet needs for patients. And it's a disease of decisions. It's not just the decisions by healthcare professionals or patients. It is everyone and supporting organisations. So our role at Pulmonary Fibrosis NI is to provide hope to patients. We try to show compassion, and we have a lot of lived experience through our trustees. We support both families, so that is the family complete, which includes children. And you may have noticed the book, which I'm not promoting, but there is a book for children. We also promote our bereaved families members. So when somebody becomes a member of our organisation, it doesn't end with the death of somebody that they have been supporting. So for example, a carer who has been attending and is a member, if they lose their loved one, we then still take that person on board. And I'll talk a little bit about that as we go through. So how do we meet our population? Well, through our websites, we use WhatsApp group, we use all the social media that you would normally use yourselves. We use booklets for information for patients. Everything that we provide to patients, any booklets, etc., we provide, our healthcare professionals have vetted before they're given out. We try to keep non-jargonistic information in, try to keep it in plain English or plain language for people to understand. We carry out community activities to try to ensure that our patients, our carers, and our bereaved family members are all involved. We will hold coffee mornings, which are great ways of people to socialise and discuss with one another, discuss their problems, make friends, find somebody who lives in their neighbourhood that they can maybe meet up with at other times just by bringing them together. We do well-being trips. Well-being trips will be a little bit more involved. It might involve a trip out for the day, dinner at the end of the day, and brought back. And they're a great way of bringing people together. We have respite facilities, which I'm going to talk a little bit more. Okay, I'm on an orange. And befriending services. So one of the things that I just want to talk very briefly about, and I think it's a critical and often overlooked need. If you look at cancer services around, I'm not sure, I can only speak from the UK, I'm not sure what it's like throughout Europe, but generally very well organised, well financed, and you'll have facilities where families can go, make memories and spend time together. That is what we have moved towards at Pulmonary Fibrosis NI. And it supports not just the patients, it supports the whole family and also our bereaved members. So the reason why we looked at respite, and I'm trying not to get a red card, by the way, Alba, is that as the disease progresses, obviously mobility will progress. Medical side effects can affect travel, high insurance and travel costs, and believe you me, I know what that's all about because I travelled here today with my wife yesterday, and I know what it's like. It's very, very difficult, especially if you're on a reduced income. So your wage, your income coming into the family because of the illness drops. So there's lots of problems that these people face. The power of respite. Well, it gives people safe opportunities to travel within their own country. So they're within their own country, their own medical professionals are nearby, they know where they're going, they feel safe. It's time to create precious memories for families. So important, especially with this disease, because we all know that it has an end date for everyone. Improve well-being for families as well, so it gets them the opportunity to get away. We have 2 respite facilities. We have a respite facility that is a 3-bedroom type facility. It overlooks the ocean, excuse me. It provides an opportunity for families to get together, and it's in a seaside resort where you can also bring the grandchildren. So you've got facilities there like a swimming pool, etc. So what does that provide? Well, we ensure that there's high hygiene standards when people get there. We ensure that it's affordable because there's no insurance costs, there's no travel costs. Oxygen can be brought and delivered there. And they can have multiple stays. So we look at the patient's needs. So we have a patient who is in need. You will get people and families who are in more need than others. And we recognize that in our community. We make sure they get as much respite and as many opportunities as possible. So, does it work? Well, yes, I can assure you it does. Our feedback, if you read our books, if you read the comments from our patients, etc., people who use the facilities, the feedback is overwhelmingly positive. People will use terms like a life-changing experience. I haven't had a holiday for 2 to 3 years. This has been unbelievable that I've been able to come here. And meaningful memories for families are made. When you think about it, we're all going about, your families, your children, everyone's going about doing their own thing. But an opportunity where you can say to parents, you can go together, you can take your children with you, you can take your grandchildren with you, an opportunity for them all to stop for a week or weekend, go away together and make some memories. So a lesson we have learned, that providing respite lets patients or families know that for every sadness they're facing, there's a joy, and when they think they've lost everything to pulmonary fibrosis, it brings them some hope. It also lets them know that there's some good in the world and that somebody is actually fighting their corner. Thank you very much. No red card.
Thank you very much, Tom, for sharing the work that you're doing and about the importance of actually creating memories with everyone. Again, the question to our audience, both here in the room as well as online, please let us know what you think. Would a model such as respite care be an urgent priority in your country? And as you're responding to that, I'm happy to invite Anne-Marie Russell up as our next speaker to the lectern.
Thank you very much. This is a rather busy slide, but I will leave it with you to absorb. Firstly, I apologise to people who are not native English speakers. There are quite a few acronyms on here, but I will caveat that by saying that this pathway is available. It's published in Action for Pulmonary Fibrosis Strategy online, so you could spend some time unpicking some of the acronyms at your leisure. When we think about gaps in care in interstitial lung disease, there are many. So thank you to Tom and Eleni for focusing on 2 very important aspects. The third is, for me to speak to, is the care pathway in interstitial lung disease. There is a great deal of disparity in patient care, not only in the UK, but throughout Europe. And so why do we need a pathway of care? I think for multiple reasons. Of course, for the patient. The patient knows what to expect from diagnosis through to reassessment, to ensure that patients have a multidisciplinary team diagnosis, they have appropriate optimal management and treatment and appropriate follow-up. But it can also be ammunition for services to cost into their pathway so that clinical services are appropriately remunerated and we can provide the care that patients need. And it helps clinicians, it can help clinicians at all stages who are non-specialists who don't understand the journey of interstitial lung disease. But later as well, just to reassess where the patient is along this journey. And so the entry point is at primary care, and it's interesting to see that 53% of people think that primary care has improved over time, which is fantastic. And when we think about primary care, we often think about the role of the GP, but the GP is in a place of struggling workloads. GP numbers are falling, and so primary care, particularly in the UK, is delivered a lot by advanced clinical practitioners who may be nurses, maybe paramedics, maybe from a different background. And so we have work to do when we're thinking about our education programs in university, about introducing understanding of interstitial lung disease and rarer diseases so that people recognise symptoms early in the disease trajectory and patients can hop onto the pathway. But before that, we also need to think about the next generation. We need to attract school children into medicine, into healthcare professions. We could be making school children aware of interstitial lung disease within an aspect of the curriculum or through outreach work. And we're starting to do a little bit of that in Birmingham. And so I think my key message is that the care pathway for interstitial lung disease must be interdisciplinary, multidisciplinary in terms of diagnostics, put the patient in charge of care wherever possible and access to electronic records where multiple professionals are involved in care for streamlining. And not to forget the importance of the whole team approach in palliative care. I think for this session, it's really important that we have some time for questions and discussion and debate. So I'm going to leave that there. Thank you.
Thank you very much, Anne-Marie. And still, we will want to hear from you also on this topic, whether you're seeing that as a priority in your countries. So here is our third poll with regards to the presentations that were held. If you could take the time to let us know what you think about this. And then afterwards, what I would like to do is actually look at the feedback from you. We've heard 3 sessions about 3 quite different aspects of care, which still all in their own rights represent substantial care gaps, be it the pulmonary rehabilitation to actually be able to live life with a disease, be it time and space to spend with a family and things being taken care of for once, or be it around the diagnosis and the treatment pathway of really bringing everyone together to collaborate with the patient at the center. So let's see what you thought about that. Could we please have the results of our 3 polls up? Hoping technology will be on our side for this. While we're actually waiting for that to come up, just to use the time, is there something from the 3 of you? I know you all said that the other topics are also important in their own rights, but is there something that stood out from any one of you? Tom?
Yeah, I think that one of the... Can you hear me okay? Yeah. I think one of the things that hasn't been mentioned is the psychological impact of either rehabilitation or respite or anything else that we talked about. And I think that all of them, that has to be taken into it. And also, when you look at the patient-carer relationship, it's also, if you've got a good carer, if you're looking after your carers as an organisation, a federation, etc., you're going to have better and healthier patients. So I think we need to look at not just the physiological, but we also need to look at the psychological impact that this disease has on patients.
If I add quickly to that, Tom, in terms of thinking of the care pathway, I think that taps into the importance of specialist centres. We know that in the specialist centres, they tend to be larger interdisciplinary teams, much more professionals, access to investigations and maybe a more holistic assessment of both physiological and psychological needs. Thank you. Sorry, Elaine.
When we talk about treatment, I think treatment is something integrated. A treatment is the medicine and all the others that you need in order to cope with your disease. An integrated care for pulmonary fibrosis, of course, need pulmonary rehabilitation, psychological support, because I think maybe psychological support is the first one, because you can't do anything if you are not mentally well. And of course, you need a nutritionist to make your diet program, because you have a lot of side effects, and you need a multidisciplinary or a multidisciplinary approach in your treatment. And unfortunately, the most of us in our countries, maybe there are differences in our countries. In Greece, for example, you are doing all alone all this because you understand what you have to do, and you are doing all alone, but you need to do it. Thank you.
Yeah, thank you very much for bringing up this important topic that I think is from probably the first symptoms through diagnosis, through the entire pathway, so important to also pay attention to the mental health and well-being. We do have our results up already, and actually the highest score goes to the pulmonary rehabilitation program that Eleni has been talking about. Then it's the integrated pathway, and actually for the respite care, even there, half the people who gave their votes said it is a priority, and actually quite a number of them say they need more information probably to understand it better. But it shows a little bit also how many things there are that we continue to work on. Talking of that, do we have any questions from online? I see a head shaking. Okay, so then to the audience in this room here, do you have any, and I see the first hand coming up all the way there in the back. Do you have a question to our panel?
Surprise, it's me, isn't it? Tom, I love respite, but I can say that in rare diseases, in a long and scarcely populated country like Norway, it might be very expensive. Would you consider having multi-diagnosis respites, several patient organization, not doing it by diagnosis, by doing it by a geographical region instead? Because I think that may be the only way to make it financially viable.
Are you referring, John, for different diseases as well, or are you saying just collectively for pulmonary fibrosis?
No, different diseases. Instead of doing it by diagnosis, we could do it by region, because you can't have respites all over. It's too expensive, right?
Yeah, and why not, John? And really, it's a government's responsibility to ensure that that's there. It shouldn't be people like me and my colleagues here that are providing that. But because they're not, it wouldn't be a bad idea at all if other organizations were prepared to get involved. The reason why I say that, John, is because from our experience, the single most impactful thing that we do is providing families an opportunity to get together, to spend time together in somewhere where they feel safe and at a very economical price. You know, so yes, I would go for anything that would encourage more of that.
Thank you.
Any other questions in the room to our panelists? Yeah, up here at the front.
Well, I just want to say a word about care pathway, integrated care pathway. The point is this access and distances, and this is often an obstacle for people to go to a specific place if they have difficulties traveling. So definitely, do you see a solution to that?
Thank you, Chantal, for that question. Yes, I think that I can only speak to the UK model because that's the one I'm most familiar with. I think we started to see a shift prior to COVID in some centres. The specialist centres that I worked in offering video consultations, and we've seen a growth in telemedicine as well, but I think the video consultation is quite helpful for when you're assessing breathing pattern. And now post-COVID, that's become entrenched. We have a model where we're devolving a lot of the prescribing to other centres, provided they meet certain criteria and with support and guidance. And so part of that is skilling up the smaller hospitals that are more accessible for patients. Part of that is ensuring that the patient can still have access to accurate diagnosis and reassessment. And a lot of the non-specialist ILD centres are now doing their own multidisciplinary team meetings. Some are linking in with the specialist centres, and I think as specialist centres we have a responsibility to be available to help people to grow in terms of their clinical knowledge. But by devolving some of the prescribing practices, it frees up time in the specialist centres to cut down on the wait time. And then hopefully appreciating that travel can be difficult. It's fewer journeys if the care is then managed locally, but with a connection to the specialist centre for support when needed.
Any more questions here from the room? Yes, here up front again.
Thank you to all the panelists. My question or my interest is regarding pulmonary rehabilitation. And in particular, my question is your perspective as a caregiver or as a patient regarding the administration of pulmonary rehabilitation by telemedicine program, which means lose the isolation favor for patients, but probably can help some patients outside the hospital, not really close to the hospital, far from the academic position. So could be an option to offer to some patients instead of pushing the patient to some structure that were probably are not really focused on rehabilitation program, could be an option for patient perspective.
Yes, all in Greece reality, and I will speak about the other countries because there are a lot of differences between countries. We have the opportunity to be in a pulmonary rehabilitation program. The patients we are in the big cities, and not in all big cities, but the most patients are far away from the centers, and we have to think about all these people that they don't know even why they have to do a rehabilitation program. They have to understand that they have to be active. They have a lot of gaps in the training about acting and exercise. So I think that when we have countries that they have a lot of difficulties, geographical difficulties, you have to cover all these needs. And rehabilitation also, that I present a very good example of rehabilitation. Rehabilitation is not something that all people have. you have to try to find a rehabilitation program. Rehabilitation programs are very short. I'm very lucky because I'm a rehabilitation program for 7 years. And also they don't have an alternative. So we have to do something in order to have all the people the possibility to be part in a rehabilitation program. For this, I'm thinking about telerehabilitation, and this have all the telemedicine, telerehabilitation, all the have to be under the control and the monitor of our doctors, because we're patients, we have a disease, we don't know how the volume we have to use in our offers. I think that is a solution. Thank you very much.
Good. I think in terms of timing, we may have a chance for one more question if somebody has still one in the room. I'm actually also appreciating we're standing between you and dinner probably, so there's one more quick question.
Hi, thank you for a nice presentation. I'm Kathleen, I'm an ILD nurse in Leuven, Belgium. And maybe the question I am missing to pose to the audience is how you rate the importance of an ILD nurse as a priority in your country. Because I think it's the ILD nurse or the specialist nurse who is the bridge between the therapy, the pharmacological therapy and the non-pharmacological therapy and the support on the other aspects of the disease. So I would like some thoughts about that.
Thank you for that really easy question, Kathleen. I think that you do a great deal of work alongside the Interstitial Lung Disease Interdisciplinary Network in the UK, which also has a European reach, to try and support the growth and development of both nurses and interstitial lung disease healthcare professionals. But that is for people who already have a role within interstitial lung disease. I think one of the challenges that many nurses in many services are respiratory nurses and have to develop on-the-job expertise in interstitial lung disease, and that's only a component of their role. So I think there is much to do, which a pathway of care can help with when you're looking at specialist costing, is to have a business case for why you may need a specialist nurse or a pharmacist in the service. And I guess once we start to collect data about pathways and we see that there is disparity, that also becomes a good political point in which to influence and change policy. But I think you're absolutely right. The nurses are the glue that keep all those stages of the pathway stuck together and keep all the professionals stuck together to make the care holistic for the patients. But I hope that's gone some little way to answering your question.
Yes, and I'd like to add that I never had a special nurse, and I think that is there's a very big gap, because when I talked before, I said that our body gives us signs. We don't understand these signs. If we have a special nurse in pulmonary fibrosis in this very difficult disease, either we don't understand the signs, the special nurse will understand it, will help us to understand early and to find a solution earlier than we will do it all alone.
Thank you very much. I know we're already at the end of our session, so I'd very much like to thank our panel, Eleni, Tom, and Anne-Marie. Thank you for what you have shared. Also, if you have more individual questions to any of our speakers, they will be around for the duration of the summit, so please feel free to connect with them maybe on some of the more in-depth questions that you may have. Thank you also for sharing your perspectives and thoughts with us here, looking at the latest one around where we need to continue to work on, and I think there's plenty of areas that we need to continue to work on together. If you want to also have a chat with us as Boehringer, we have a booth over there, so please feel free to come by and talk about maybe the Bridging Care Gaps report. And we also have a wonderful wall that you can put your wishes and your thoughts and maybe your care gaps on with writing on a wall, so feel invited to come over. And with that, thank you very much, both here in the room as well as to our audience online. And I will hand over to Alba for some last information on this evening.